Hello and welcome everyone. My name is Bradley Findlay and I'm currently a final year Biomedical Sciences student at the University of Manchester. So for my final year project, I have created a science communications podcast aimed at shedding light on a rare disease called NF2 related schwannomatosis. Thanks to the sponsorship of NF2 BioSolutions, I have had the privilege of working closely with Professor David Bruff's lab. Here, dedicated researchers are exploring innovative ways to slow or even halt tumour growth in individuals battling this condition. This experience has allowed me to meet both the courageous individuals living with the disease and the trailblazing scientists leading research in this area. As we dive into this podcast, I hope to offer you a window into the challenges and triumphs of those affected by NF2 related schwannomatosis. And this podcast comes at a particularly meaningful time, closely following Rare Disease Day, celebrated on February 29th. Our release aims to echo the call for greater awareness and support for rare diseases. It's also important to clarify that NF2 related schwannomatosis was previously known as neurofibromatosis type 2. This change, made in 2022, more accurately describes the specific tumours associated with the disease, as neurofibromas are not a characteristic of NF2. Throughout the podcast, I will simply refer to the disease as NF2 for short. Now, let's not wait any longer to delve into remarkable stories of bravery and innovations in research that hold promise for a better future for those battling this rare disease. Welcome to our podcast. I'm joined here with Gareth Evans and Grace Gregory, two people I have been most privileged to work alongside while studying NF2-related schwannomatosis. So if we could start off by you both maybe giving a little bit of a general introduction as to why you're studying NF2-related schwannomatosis and what you're doing for the community.
Absolutely, I can go first if you want, Gareth. Save the best till last. I am an NF2 BioSolutions funded PhD student. I'm in my final year. I'm studying here at Manchester, and I'm looking at new ways that we can prevent tumour growth in people with NF2.
So I'm Professor Gareth Evans. I'm a consultant in medical genetics, but Professor of Cancer Epidemiology and Medical Genetics at University of Manchester. And I've been studying NF2 since my thesis between 1990 and 92, carrying out the first large-scale epidemiological study of NF2, and then subsequently being involved in identifying genetic changes and describing the genetic landscape of NF2 and being involved in developing treatments and improving management, which we hope is now having a big effect, not only on length of life, but quality of life.
So, what is NF2-related schwannomatosis?
NF2 is a genetic disorder characterized by the growth of non-cancerous tumours in the nervous system and is estimated to be seen in around 1 in 33,000 live births. It also affects males and females in equal numbers and does not discriminate based on ethnic group. And symptoms of the disease usually appear during puberty or in early childhood. The most common tumours associated with NF2 are vestibular schwannomas, also known as acoustic neuromas, which develop on the nerves that carry information from the inner ear to the brain. These tumours can lead to hearing loss, ringing in the ears, problems with balance, and muscle weakness. Other common tumour types often seen in patients with NF2 are meningiomas and ependymomas, which are tumours that occur in the brain or spinal cord. So NF2 is caused by mutations in the NF2 gene located on the chromosome 22, which produces a protein known as myelin. Myelin is essential in controlling cell growth, and its malfunction allows cells to divide uncontrollably, forming tumours. So the disorder is inherited in an autosomal dominant pattern, meaning that having just one copy of the mutated gene inherited from one parent is enough to cause the disorder. However, approximately half of NF2 cases are caused due to spontaneous mutations, meaning they occur in individuals with no family history of the disease. So the symptoms of NF2 can vary very widely and may include gradual hearing loss, ringing of the ears, balance difficulties, facial muscle weakness, numbness or weakness in the limbs, and changes in vision and seizures. So the current treatment options for NF2 associated tumours include surgery, which is currently the primary treatment for removal of small vestibular schwannomas or meningiomas. However, the best course of action is decided based on the risk involved in damaging the facial and trigeminal nerve, which is responsible for facial and auditory function. In some cases, this can be incomplete removal of a tumour. So radiotherapy is another alternative to surgery and an effective treatment option for small tumours along the auditory nerve as well as meningiomas. And these interventions are often used in combination with other forms of therapy, such as medications, to control tumour growth.
What factors influence the severity of disease?
So what we know is that the severity of the NF2, how it affects you in terms of how many tumours you get and how early you are affected with tumours, can be determined to some extent by the type of genetic fault that you have. For instance, NF2 patients who have just one building block, one amino acid changed in the protein, can have, a near normal life expectancy with perhaps only ever developing tumors on both hearing and balance nerves. Whereas some patients with what we call truncating variants, these are genetic faults which stop the formation of the protein and therefore do not give you a proper functioning protein, and the non-functioning protein may interfere with the actual normal protein. These can have a more severe disease course. The other main thing that affects severity is if you're mosaic. So being mosaic means that fewer of your cells are affected. So if you only have 1 in 100 cells affected, you might expect you to have a disease that's only 1/100th as bad as someone who has all of their cells affected.
Now for some patient stories.
So one story in particular that grabbed my attention was the story of a young woman diagnosed with NF2 at the age of 22. After a general appointment with the doctor sparked by headaches, dizziness, vomiting, and loss of hearing in her left ear, she was then advised to do an MRI of the brain and spinal cord, where she found bilateral vestibular schwannomas and several brain and spinal cord tumours. This is when she was diagnosed with NF2-associated schwannomatosis. So shortly after this finding, she had a major brain surgery to remove a large tumour, compressing her brain to one side and causing many dangerous symptoms. In spite of all these life-changing discoveries, she completed medical school and went on to practice emergency medicine for 12 years. So her complications continued due to NF2, and she developed complete deafness and vocal cord paralysis, which prevented her from speaking or breathing properly. And this was treated by a tracheostomy tube through her neck. So in her story, she goes on to describe the symptoms that she currently deals with on a day-to-day basis, which includes vision problems due to cataracts, severe dry eyes, partial retinal detachment, chronic pain and fatigue, inability to chew or swallow, facial nerve paralysis, muscle weakness, amongst many other symptoms. If you want to explore other patient stories published by patients themselves, you can visit the NF2 BioSolutions website, where you can find many other stories of individuals with NF2. And I'm also going to link below a particularly touching story of 4 very young girls currently battling NF2, posted on the NF2 BioSolutions page, I Need a Cure.
The diagnostic criteria.
The current criteria for diagnosing NF2-associated schwannomatosis includes bilateral vestibular schwannomas, so that is tumours on both sides, or a first-degree relative with NF2. In addition to either unilateral vestibular schwannomas, that's a tumour on one side, or any 2 of the following. So meningiomas, gliomas, schwannoma, which are all types of tumours, or juvenile posterior lenticular opacities, which are a type of cataract that affects the lens of the eye. Other factors such as physical exams, imaging studies, audiograms to evaluate hearing function, and genetic testing can contribute to the diagnosis of NF2. And the diagnostic process can vary depending on the age of the individual, with some symptoms taking years to develop fully. While there is no cure currently for NF2, treatment focuses on managing symptoms through regular monitoring and addressing issues as they arise.
First steps following diagnosis.
So if someone's been newly diagnosed, normally that means they've had a scan that has revealed tumors on both hearing and balance nerves, bilateral vestibular schwannomas. You would bring them into clinic to have a discussion and assess their current situation. So if they had previous scans, you would look to see if you can see how fast the tumors are growing, and to assess what imaging they have had done. So at baseline, we would want to have full imaging of the brain and spine to make sure that we have the full picture of where the tumors can be compressive within the brain or spinal cord. And also to assess their current neurology and symptoms. There will be a decision as to whether any of the tumors require immediate treatment. Normally, we would want to wait until we at least know what's going on and what's growing. But sometimes a tumor can present clinically where it does need immediate treatment. And then obviously that is usually a neurosurgical issue, because any tumor that is causing significant problems is unlikely to be able to be treated with radiation treatment, although bevacizumab, which is the anti-VEGF infusion drug, might be an option in certain situations for schwannomas. We would obviously therefore take a full history, do a full neurological examination, look at any previous history, any drug treatment or radiation that the patient had had before. Radiation can induce tumors in NF2. That's one of the reasons we use it sparingly in NF2, particularly in younger patients where it's more of a problem, as it can have a higher chance of causing tumors going forward. We would also take a family history to determine whether or not the NF2 could have been inherited from one of the parents, and also if there are children or siblings at risk. As has been said by Bradley, at least, well, in the literature, at least 50%. We actually have a paper now saying it's more like 73% of NF2 is de novo. And I think the confusion has been because a lot of mosaic patients with NF2, where the gene change is not in all of the cells, but still they qualify as having a diagnosis of NF2, have not been included in the statistics. So when you do include those with mosaic NF2, about 73% are new onset with no family history, and about half of those are mosaic, where the gene fault was not present in the egg or sperm that made that person, but it occurs later in embryogenesis and therefore only affects cells patchily around the body and maybe only in one segment of the body. Genetic counseling will form part of that initial assessment, and then obviously developing a management plan for that patient. How soon will they get a new scan? Certainly, probably within 6 months to assess tumor growth, and then a plan of usually doing head scans annually going forward, spine scans every 3 to 5 years, 5 years if there's no tumors on the initial scan. And obviously talking through the potential treatment options, including watch and wait, but also drug treatments. Bevacizumab is the only approved treatment in the UK at the moment. It is likely, with the amount of research in NF2, there will be more treatment options medically. The ideal situation is to find a treatment that has very minimal side effects while still having a potent action on the tumors.
Hearing rehabilitation.
So obviously the first thing is, can you actually improve the hearing with treatments? Sometimes in an acute setting, you can use steroids to reduce inflammation if someone has had a sudden hearing loss. and that can be quite effective, but only in a short-term way. Bevacizumab does have an effect on hearing loss in some people, particularly again when that hearing loss has been acute, and can preserve hearing for longer. But in terms of rehabilitation, the first thing is hearing aids, and trying to improve the hearing by using hearing aids. And you can have, where someone is not hearing on one side, you can have a cross-ear hearing aid to give some idea of hearing on both sides. Once the hearing is lost completely, it depends on whether the cochlear nerve, the hearing nerve, is still intact. If it is still intact, then you can use a cochlear implant to rehabilitate hearing. And cochlear implants can be very, very effective. The hearing will still need to be relearnt, but it can provide a really quite good sound, which people can learn again how to hear, and can, in many instances, use on a phone without the visual impact of looking at the mouth. Less good, but still works for many people, is an auditory brainstem implant, and that is an implant that is put directly onto the cochlear nucleus of the brain, and sends signals out via a receiver on usually held with a magnet on the side of the head. The drawback of these is that unless the magnet is replaceable or removable, it makes doing the MRI head scans more tricky. You actually have to wrap the head to keep the magnet in place, otherwise it'll jump around all over the place. So ABIs and cochlear implants have a very important place, although the success rate with ABIs is substantially less than with cochlear implants, but you can only have a cochlear implant if the hearing nerve is intact.
Current research focuses.
So the two projects currently being pushed forward by NF2 BioSolutions are gene replacement therapy. So this works by delivering a functional NF2 gene to replace the faulty NF2 gene to restore myelin protein function. Because as we know, NF2-associated schwannomatosis is caused by the myelin protein malfunction. And this is currently being researched at Dr. Catherine Mayer's lab at the Nationwide Children's Hospital. The second project currently being pushed is the immunotherapy approach, where researchers are using bacteria to induce the patient's own immune cells to attack the tumors. And this was initially developed at Harvard Medical School in Dr. Gary Brenner's lab.
What is the need for new therapeutic options?
So, Gareth, as you mentioned earlier, bevacizumab is the only approved drug available for people with the disease. So, for the people that don't know, bevacizumab is a drug marketed under the trade name Avastin, and it is essentially a medicine engineered to block growth of blood vessels into tumors, depriving them of oxygen and nutrients needed for growth. So this can slow the growth of tumors or even reduce their size. So I come across an interesting meta-analysis that was done that included 8 observational studies of around 160 patients taking a treatment course of bevacizumab for vestibular schwannomas for a median length of about 16 months. So in this study, they found that 41% of patients had partial regression of their VS, and 47% saw no change in the tumor size. They also measured the effects of this medication on hearing ability, and they found that hearing improved in 20% of patients and remained stable in about 69% of patients. So from these studies, we can see that bevacizumab is actually quite effective at slowing the rate of tumor growth, and in some cases even halts it. Where the problems arise, though, is down to the toxicity of this drug. In the study, they found that 41% of patients had partial regression of their VS, 40% of which saw no change in the tumor size. And they also measured the effects of this medication on hearing ability, and they found that hearing improved in 20% of patients, remained stable in 69% of patients. So from these studies, we can see that bevacizumab is actually quite effective at slowing the rate of tumor growth, and in some cases even halts it whilst the medication is being taken. Where the problems arise, though, is down to the toxicity of this drug. So in this same meta-analysis, the incidence of serious toxicity was around 17%, and the most common side effects were loss of menstruation or very heavy blood flow, and unusually high amounts of protein in the urine, hypertension, thrombosis, which is issues with blood clotting, anemia, and a higher risk of developing serious infections. So this highlights the need for more therapeutic options for NF2 patients, as treatment options are currently very limited.
What is the process of getting new therapeutic options approved?
So I'm currently a wet lab researcher, so my main focus is taking potential therapeutic targets and then working on them in the lab to see if they might be viable for NF2 patients. But one method that we mainly like to use for getting drugs quickly to people who need them is drug repurposing. So drug repurposing is used when there has already been a therapeutic agent that's been approved for another condition, and then that has already been through extensive clinical trials for safety in humans and efficacy in disease. So we already know that this has already been safe and approved for another condition. So we can use this therapeutic and hopefully repurpose it for NF2. And this means that it doesn't have to go through as extensive clinical testing because lots of the safety profiling has already been done. So this means that we can sort of fast track a therapeutic agent straight through to patients with a lot less of the clinical trials and testing that would otherwise be required for a new agent that had never been used in humans before. So some ways we can think about fast tracking this process is to look at many potential agents in the lab. So for example, we have Schwann cell lines, which are the cells that actually go on to produce vestibular schwannoma, for example. So we have Schwann cells in the lab that we can test new therapeutic agents on to see if it might reduce the growth of these schwannomas. And we've also got meningioma cell lines, for example, that might go on to produce meningiomas in patients. So we can look at these different agents in meningiomas. And we can also look at these immune cells as well. So like you said, Bradley, immunotherapeutics are going to be a potentially really good route for new therapeutics for people with NF2. So it's quite important for us to always take into account not only the tumorigenic cells themselves, like the schwannoma, the Schwann cells, and also the meningioma cells themselves, but also the immune cells that move into these tumors. And we need to know how we can potentially stop these immune cells moving in or change their actions within the tumors. So we can actually do that all within the lab, and that's in the cell lines. But we can also do that in animal models as well. So we can actually take these potential immunotherapeutics or other types of therapeutic agents and put them into an animal model to see if we can reduce tumor growth actually in the animals first before we go on to then use that in humans. So this is a really good way of first validating these in cells and in animal models before we do a small window study, for example, in people with NF2 with a previously approved therapeutic for another condition. And this means that we can actually get therapeutics out a lot faster for someone with a rare disease, for example, someone that really needs it on a compassionate use case. For example, in NF2, when maybe they don't have other treatment options available, maybe they don't have an option to use bevacizumab, for example, and maybe their tumor is non-resectable, so they can't have surgery for it. So getting these to patients where in a small window study that gives them another therapeutic option can be a really good way of getting the drugs to people that need them.
As we wrap up the episode, I want to take a moment to thank each and every one of you for joining us on this important journey. Conversations like these shine a light on the paths less travelled, bringing hope and support to those affected by this rare disease. In our time together, we have shared stories of resilience, explored the latest research, and discussed challenges faced by those living with this condition. But our conversation doesn't have to end here. Awareness is the first step towards change, and there are numerous ways you can contribute to this cause. Firstly, if you or someone you know is navigating the complexities of this disease, please remember you are not alone. There are incredible organisations dedicated to providing support, resources, and a community for those affected by NF2 associated schwannomatosis. I encourage you to reach out to the NF2 BioSolutions and NF2 Patient United. I will have their websites linked in the description. Secondly, for those who are moved by today's stories and are looking for a way to make a difference, consider making a donation. Even the smallest contribution can have a significant impact. You can find donation links on the websites of NF2 BioSolutions and NF2 Patients United, and I will include direct links to donate in the description. Together, we can make a difference. Whether it is through spreading the word, educating ourselves and others, or contributing to the cause, every action counts. Let's continue to support each other, foster hope, and work towards a future where this rare disease is no longer an unseen struggle, but a challenge met with unwavering support and understanding. Thank you once again for tuning in. Be sure to follow NF2 BioSolutions and the University of Manchester Faculty of Biology, Medicine and Health on all social media channels to stay updated on our journey towards making a difference. Until next time, take care of yourselves and each other.